Hi, my name's Alana Dinsdale and welcome to my practical on the assessment of temporomandibular disorders. In today's practical, we're going to be running through a subjective examination for temporomandibular disorders. We're going to be running through the objective examination and talking about some outcome measures that you can be taking that you can then use to reassess progress following an intervention. So my background, I'm a clinical physiotherapist that works in a private practice setting, and I also lecture and research at the University of Queensland on the topics of temporomandibular disorders, as well as a number of other musculoskeletal complaints. My key area of research is looking at disability as well as management of those presenting with TMD in a clinical setting. Okay, so when we're talking about the subjective examination, for people that are presenting with potential temporomandibular disorders or TMD, there's two main things that you should be able to do by the end of the subjective examination. The first of these is we want to know, is it a TMD or is it something else? The second thing is, if it is a TMD, we want to know what kind of TMD it might be. So very broadly, temporomandibular disorders, we kind of categorise into two main subgroups. Those that are characterised primarily by pain, and those that are characterised more by mechanical symptoms like clicking, clunking, locking, crepitus. And a lot of the time we might have both of these going on, or we might have one on one side and then another on the other side. So the subjective examination, by the end of it, we should really be able to understand what this person is presenting with and have a few key things that we're going to use to guide our objective examination. So when we're talking about, is it a TMD, there's a few things within our subjective examination that we're looking for. So when we're running through our usual structure, so we're gaining information about the history, current history and previous history. We're also gathering information about the behaviour of symptoms, including aggravating and easing factors, what kinds of symptoms they're experiencing, like pain, locking, clunking, crepitus, and our usual 24-hour pattern of those symptoms. We want to be, when we're trying to figure out if it's a TMD or not, they really should be behaving like mechanical conditions. So we should have some really clear aggravating and easing factors that typically are associated with jaw activities. So they might come in and describe, I'm having problems when I open my mouth, or when I yawn, or when I'm eating or chewing down, so loading type activities. They might also report problems with activities that we don't typically associate with jaw problems or jaw movements, so things like sleeping, but they might be clenching when they sleep. So if they're reporting pain first thing in the morning, we might want to be knowing, do you know if you clench when you're asleep or grind your teeth? Has your dentist told you? Has your partner told you? Do you know whether this is something that you do? So even those things that we might think maybe aren't related to jaw activities, we can dig in a bit more detail to try to determine, is this something mechanical or is it not? Exactly the same applies with stress. So often people will say, when I'm more stressed, my symptoms are worse. And we want to be understanding, is there a mechanical factor that underpins that? So when they get stressed, are they clenching and grinding their teeth? And that's what's exacerbating the jaw problem. We also want to know during this, is it TMD, is it a TMD or not? We want to know, is there any other contributing factors that we might need to be looking at within our physical examination? So this includes things like a history of cervical disorders, including headaches. So if somebody's been coming in saying they've got, a 5-10 year history of cervical spine problems, neck pain, headaches, even cervicogenic dizziness, maybe they've received treatment for that in the past, we want to be understanding where the TMD might fit into that. The second part of the subjective examination that we should be able to answer by the end of the patient interview is have a bit of an understanding of what kind of TMD it is. So when we're trying to understand this, a really important question is around those special questions or special symptoms. So are they experiencing pain? Are they experiencing any mechanical symptoms like their jaw clicks, locks, they feel it kind of grating or grinding when they move it? And sometimes these mechanical symptoms might change over time. So they might have reported a history of their jaw clicking and then suddenly one day it started locking. Or they might say, yeah, it locks every now and then, but it's usually a click that we experience or that they experience. So understanding what kind of symptoms they're experiencing can be really, really helpful in determining from the start what we think might be going on with their jaw. The other thing that we kind of need to understand with these symptoms is the relationship between the two. So is there one symptom that's there all the time? Is there one symptom that's bothering them the most? Or is it a combination of these things? So perhaps they experience clicking when their jaw locks, then they experience pain when they're trying to kind of force through that. So we want to understand the relationship between these different symptoms that they might be experiencing. When we're talking about relationships, we also want to be understanding the relationship between the left and the right side of the jaw. So it's really common because with TMDs, we have this bone that connects the left and the right side, the mandible. So it's really common that we might be interviewing someone that reports pain on one side and then clicking on the other, or vice versa. So if that's the situation, we kind of need to understand in the history which one came first, how those two sides relate to each other. So maybe they get symptoms on the right, but then the left side plays up or feels really tight when the right side's particularly bad. So we need to be getting a gauge of that within the interview. The other thing that can be really helpful within the interview that we can use to be guiding our physical examination is understanding whether their main problem is more with opening activities or whether it's more with closing activities. So are they experiencing more problems when they open their mouth, when they're yawning, maybe when they're talking, even when they're trying to open their mouth to fit food in? So they might be fine with small pieces of food, but then when they're trying to bite into an apple or eat a really big burger, that's where the problem is. Compared to somebody who reports problems when they're closing. So these people might say it doesn't matter the size of the food, but if it's really chewy, that's what really flares me up. So we can start to think what type of TMD might be going on and what kinds of things this person might be struggling with. And we need to really make sure within the physical examination that we're assessing those things that they're having problems with, and we're capturing their main problematic symptoms with our outcome measures. So if somebody's main problem is clunking or locking, and our only outcome measure is a VAS of pain, that can be problematic when it comes to measuring meaningful progress within management. So when we're talking about outcome measures, there's a number of different things that we can gather within the patient interview. We can be getting more personalised or customisable outcome measures, so asking things like VAS, the patient's specific functional scale. So if somebody reports problems eating, for example, we might ask them on that scale of 0 to 10, 0 being they can't do the activity at all, 10 being they can do it perfectly normally, like they could without a jaw problem. Where are they at the moment? So we can be using customizable outcome measures. We can also be using some more formal self-reported outcome measures that are standardized and help us compare over time as well as to other people or normative values within the literature. So a couple of examples of these include your jaw functional limitation scale, which is heavily focused on activity, and it runs through a number of different items relating to mouth opening, like yawning, as well as eating different varieties of food. So that's a really handy outcome measure if we're trying to get a global view of what impact their jaw problem is having on their activity. There's also other outcome measures, particularly if we're picking up that potentially this person is having a problem with kinesiophobia, pain catastrophizing. We can be looking at scales like the Tampa scale for kinesiophobia for temporomandibular disorders. So that's been adjusted from the normal or the usual Tampa scale, and it's more targeted for people with jaw problems. And then there's also questionnaires like the pain catastrophizing scale, the oral health related quality of life index. Measures like that can sometimes be helpful to give us a more standardized broad view of what might be going on and where their baseline is. So lastly, within the subjective examination, some key things that we might need to dive into that we wouldn't in other areas of the body, that are specific to TMD and that we want to make sure that we've asked about so that we're understanding the complete problem, is things like their dental history. So have they had braces? Have they had any interventions that might change either their bite, so how their teeth are lining up on each other, or how they functionally use their jaw. So for example, if they've had teeth removed, their molars on one side, maybe they've suddenly started chewing all the food on the other side. So we want to make sure that we're understanding that dental side of things as well. And then, like I said earlier, we also want to make sure absolutely that we're getting a thorough understanding of what's happening in adjacent areas like the cervical spine, even the scapulothoracic, like if they're reporting shoulder problems or thoracic problems as well, because all of these areas, as we'll see within the objective examination, all of these areas are going to have an impact on how the jaw functions. Okay, so that's a brief summary of how we would do a subjective examination or what we would include in a subjective examination in people that are presenting with jaw problems. Just a quick summary is by the end of the interview, we want to be understanding first and foremost, what's this patient's main problem? What are they coming in for today? What do we need to make sure that we're capturing within their assessment and with outcome measures moving forward? For some people that might be pain, for some people that might be symptoms like locking. We also want to make sure that we have an understanding of our patient's goals and expectations within physiotherapy as well as within management as a whole. And we want to know those two things. Does it sound like it's a TMD? And if it does, what kind of TMD is it? So now we're going to be moving on to our objective examination, which is going to help us answer that second question a little bit more. Okay, so now we're going to be running in through our objective examination of someone presenting with a TMD. So today we're joined by Jack, who's going to kindly be the patient. For the objective examination, the key things that we're looking to get from it are by the end to be able to say, what's going on, so have a diagnosis of TMD and have an understanding of what might be contributing to that. So is it localized or purely the jaw joint and the surrounding structures like the muscles, or is there more that's feeding into it? So for example, is the cervical spine playing a really big role, and we might need to include that or target that within management. We might also be needing to have a look at the scapula, as well as any dental things that might be contributing to this person's jaw problem. By the end of the objective examination, we also want to be really understanding that interplay between the left and the right jaw. So we want to know what's contributing to the symptoms that they're having problems with, and it's not always the side that we think might be the side from the subjective interview. So whenever we're starting our objective examination for somebody coming in with a jaw problem, we want to be starting off getting a really broad overview of what areas might be influencing and what's happening around that jaw that's setting it up during those movements. So to begin with, I would usually get patient ideally shirt off so that we can be having a look at what's going on through the cervical spine, through the thoracic spine, and even out through the shoulder girdle as well. So we want to get an idea when he's just sitting there at rest, where is his head, his neck, his shoulders positioned in space. We're also going to be considering from the side, getting a bit of an idea of where his head is sitting on his neck, because that's going to influence how somebody's jaw sits at rest as well as how he moves. So for example, Jack, if you were slumping over, and everybody at home can have a go at this, so just keep looking straight forward. If you've got somebody sitting there with a really kyphotic posture, a really forward head position, that changes. So have a feel of where your teeth are articulating or where they're sitting on each other, compared to somebody that's in a much more upright position. It changes where that jaw is sitting at rest, which is always going to change how it functions. So it's really important in our objective examination to be starting off getting an overview of what is going on and what the starting position for that jaw is. So once we've got a bit of an idea of what's happening through the scapulothoracic region, as well as up through the cervical spine and the head on neck posture, we want to be coming around to the front and having a look at specifically with the jaw and the face. So we're wanting to get an idea of things like, is there symmetry between sides? We can be looking at these angles of the mandible and just seeing how they are side to side. Are they relatively symmetrical? From a structural point of view, we're obviously not going to be changing somebody's facial structure within physiotherapy, and that's certainly not an aim, but it's helpful to know what that person's baseline is. We also want to be getting an idea of whether they're sitting in an overbite or an underbite, so whether that jaw is sitting really far forward, which is an underbite, or whether it's sitting really far back, or whether there's a very slight overbite, which is pretty normal. So I can be getting a bit of an idea of that just with mouth closed, but the other thing that you might do is just get the patient to smile, please. Yep, so you want to have a look at teeth, so smile with your teeth. Good. So I'm just seeing where his top front teeth sit on his bottom front teeth. And I want to be seeing the overlap between the two. We can also be getting an idea in this position of things like, is there any obvious swelling? Is there any obvious redness or bruising? So that might be particularly important for someone presenting with acute TMD. We want to be making sure that we're not dealing with anything more sinister. So from our subjective examination, we'll already have a bit of an idea of whether we think the cervical spine might be involved or not. Even if we don't think that it is, it's still really important within the objective examination that we're at the very least screening the cervical spine, because there is so much overlap between the cervical spine and the jaw. So for this, we're already having a look or getting a bit of an idea of what's happening through that head and neck position and the cervicothoracic, the scapulothoracic area. If we're suspecting, based on the interview, based on what we're observing as well, that maybe there's a more scapulothoracic or shoulder involvement, we would absolutely be going down that pathway and doing an active range of motion assessment of shoulder movements and potentially of thoracic movements as well. For this practical, we're going to be focusing on the cervical spine and on the jaw because this is the most common presentation of people presenting with jaw issues. So for cervical active range of motion, I'm not going to change any of Jack's posture to begin with. I just want to see how he's moving when he is moving in his normal position. So I haven't said anything to Jack about anything I'm picking up on with observation yet. For active range of motion of the cervical spine, so Jack, what I'm going to get you to do is turn your head as far over your right shoulder as possible. Good. And then come back to the middle. And then going as far to the left as possible. Good. Back to the front. Perfect. Can you please tilt your right ear to your right shoulder? Good. And then coming back up. And then going as far as you can to the left as well. So as he's doing this, I'm always going to be getting an idea of what's limiting him. If he's limited in a specific direction, I'm going to be using a goniometer or a tape measure to be quantifying that as an outcome measure. And I'm always thinking, if Jack's come in with right-sided jaw problems, how might that marry in with what I'm seeing happen in the cervical spine? So for example, if he's coming in with problems on the right TMJ, he might have problems turning his head to the right. And then when I say what's limiting you in that position, he would often say, you know, I feel pain or I feel stiffness on that right side, or I just feel like I can't go as far. Vice versa, you might actually see problems going the opposite side. So if I get you to turn all the way to the left, if he's having right-sided issues and there's a contribution from that right cervical spine as well, he might be reporting a lot of tightness that comes down through those, for example, upper traps or even levator scap area. And I'm starting to build this picture of how the cervical spine is interacting with the jaw. So just come back forward. We're also going to be having a look at cervical flexion and extension. So Jack, I'm just going to get you to look all the way to the floor. Let me know what you're feeling in that position, as far as you can go. Good. And then looking all the way up to the ceiling. Good. And then back forward. With our cervical assessment, we also want to be getting an idea from the side what's happening around that craniocervical area. So Jack, I'm going to get you just to look up to the ceiling again, and I'm just having a look to see how his head on neck is moving, what's happening in that upper and lower cervical spine. And then looking straight ahead, good, and then looking down to the floor. Perfect, and then back forward. Where necessary, you can also be coming around to the back and having a look at when he's doing rotation and lateral flexion. Sometimes it's helpful to see from the back what's happening around that scapulothoracic area, and seeing if there's any compensatory strategies, like him, for example, lifting up his shoulder as he's turning his head. So now we're going to move on to our active range of motion assessment of the temporomandibular joint complex. So we're looking at how that jaw moves. So we're going to, during an active range of motion assessment, we're going to be doing this in 3 ways. The first thing that we're going to do is just observing. So we want to look and see what happens when he's moving, how might he be compensating, and what his normal pattern of movement looks like. Again, as with cervical range of motion, we're doing this without any postural correction yet. So I haven't touched his posture or altered his posture since we've done that observational assessment. I just want to see how this jaw moves in the position that he would be using it outside of this clinic setting. So Jack, what I'm going to get you to do now is open your mouth as wide as you can. I want you to let me know during this if you're getting any pain, discomfort, any of those symptoms that you described to me during your interview, okay? So open your mouth as wide as you can, good, and then close. And I'd often get Jack to do this a number of times, so the reason being is I'm checking for consistency of movement. So during this, I'm going to be having a look at how that jaw is moving in that sagittal plane. So as he's opening, common patterns that we'll see with jaw movement is either a straight movement, which is what Jack's demonstrating here. So you can see throughout the movement, his jaw is moving in a straight pathway. We might also see a deviation. So that's when it swings to the side and then back to the middle. So Jack, can you just try and demonstrate that? Yep, so as he opens, you'll see it's like a V. So I always think deviation. Deviation has a V, it swings out to the side and then it comes back to the middle. We're definitely wanting to get an idea, if they've got a deviation, we want to get an idea of what side that deviation is occurring to. So if he's got right-sided jaw problems and he's swinging to the right, already I'm starting to think maybe there's something on the right that's restricting those initial phases of movement. If he's got symptoms on the left, we've got to be asking, why is he getting a deviation to the right? Is it muscle problem? Is it motor control? Is it that something on the right is actually getting stiff or stuck and that's causing the jaw to swing to the right and then put a little bit more pressure on that left side of the jaw in those initial phases of movement? So we're looking at deviation. So when he opens, if I'm seeing that he swings to the right, I'm going to watch him do that a few times and just see if it's a consistent pattern of movement. So Jack, can I get you to keep opening and closing your mouth just as wide as you feel comfortable? Good. So then in my notes, I can be recording whether he's getting Good, thank you. Whether he's getting a consistent deviation to the right or whether he's getting an inconsistent deviation or inconsistent pattern of movement. The other movements or compensations, I guess, that we might observe during jaw opening is a deflection. So what that means, instead of the V shape, he's getting more of a J shape. So at the end of the movement, he's stuck to one side and it's not coming back to the middle. So if I'm watching him open and his jaw is swinging off to the side, again, I'm matching that in with what I've heard in my subjective examination, what side or sides is he getting symptoms on, and how does that marry up, what structures could be causing that. If he's inconsistent, I might see out of 3 or 4 repetitions, I might see him do straight one time, deviate one time, and then deflect another time. So that's really important. It's probably starting to make me think maybe there's more of a motor control problem or a proprioceptive problem compared to something, you know, maybe being tight or getting stuck and restricting that joint range of motion. So mouth opening is one of the most commonly affected movements in people that are reporting jaw problems. The other movements that we need to definitely be having a look at in a comprehensive jaw assessment is laterotrusion, so seeing what's happening when he moves his jaw side to side. We also want to be having a look at protrusion and even retrusion if it's relevant. People won't get a lot of retrusion movement, it's usually a mil or 2. So Jack, what I'm going to get you to do now is I want you to move your jaw as far as you can to the right. Let me know if you get any pain, clicking, clunking, stiffness, anything like that. Good, and then back to the middle, and then to the left. Good, and then back to the middle. So what I'm observing with this is, first of all, can he do it? So if somebody's got poor proprioception of what's happening around their jaw, what we might see is that I say, can you please move your jaw as far as you can to the right? And he moves to the right. This is a really good example.
Yeah.
Yeah. And then back to the middle. So what we might see if somebody has poor proprioception around the jaw is if I say, can you please move your jaw as far as you can to the right? He might move to the left, or he might go a few different movements and go, is that right? He doesn't really know where his jaw is in space. That's already, again, really important for me when I'm thinking of what might be going on, is it's starting to raise that flag of maybe there's some proprioceptive motor control issues going on with this patient. So we're going to be having a look at going side to side. I'm also going to just be starting off by eyeballing the movement. Does he look roughly like when he moves to the right?
I'm in my head now.
Yeah. So when he moves to the right, I'm looking at the center of his chin, and then when he moves to the left, does it roughly look like he's moving the same distance? Is he reporting any symptoms when he goes one side over the other? And again, we're matching this in. If he's coming in with right-sided TMJ pain or clunking, I want to know when he's moving to the right, how does that compare with moving to the left? Side-to-side movements, there's a number of different things that can contribute to problems with this. A really big one is often the pterygoids, so the medial and lateral pterygoids, which we'll have a look at in a minute. But the pterygoids move the jaw side to side, and they often play a really big role in the disc movement. So as he's opening his mouth, that disc needs to be sliding forward with the condyle. In lateral pterygoid issues, there might be a coordination problem or a tightness issue that's limiting how that disc is moving that can be presenting with symptoms like clunking and locking. So we're going to be having a look at the side-to-side movement. We're also going to be having a look at forward movement. So can I get you to move your bottom teeth forward? Perfect. And then back. Good. Now this one's a bit funny. I want you to move your jaw back as far as possible. Yep, you're not going to get very far. Good, and then relax. And I'm also having a look at what's happening when he's doing all of these jaw movements, what's happening up through the cervical spine, even down through thoracic shoulder blades as well. So for example, with Jack, you would have just seen when he pulls his jaw back, he's retracting his head a lot as well. We're wanting to be picking up on this, not correcting anything, but just getting an idea of how his jaw is moving and functioning during a normal active range of motion assessment. So once I've observed what's happening when Jack moves his jaw in opening, side to side, forward and back movements, then I want to be getting a measure. So I can be using this measure as an outcome measure following treatment in the future. I can also be using this measure to get an idea of what movements might be affected that's going to help with my clinical reasoning of what's going on. So Jack, I'm going to get you to open your mouth again as wide as you can. Again, let me know if you're getting any pain or discomfort, any noises when you do this. I'm just going to be measuring, so this will be lining up between your teeth, so I'm measuring from the top teeth to the bottom teeth. A really useful landmark for this is I'm measuring between the middle, so that line between the top two front teeth, and then the same line on the bottom two front teeth. So Jack, I'm going to get you to open your mouth as wide as you can. Good, and then I'm coming in with my ruler and measuring that line, so the middle line at the top and then the middle line on the bottom teeth as well. Okay, good, and then close. Usually the normative range varies pretty significantly, so it's really important to get an idea of if what I'm measuring is normal for him. I can just ask my patient that, does that feel like that movement is as far as you could normally go? Or is he getting any pain, clicking, clunking that's limiting it? Normative values, anything less than about 30 mil definitely starts to impact on function. Anything more than about 50 to 55 mil, we're definitely starting to kind of think about hypermobility. You can obviously see that range is pretty broad. So I'm wanting to get an idea of what his current range is. Does it typically fall within that range, normative range limit? So is he between 30 and 50 to 55? Does it feel normal to him? And if it doesn't, what is he feeling limits him during that movement? I'm also going to be measuring side to side. So I want you to move your, actually, come back to the middle. So before I measure side to side, because we're using those same landmarks, I just want to get an idea of, are they lining up? In which case that he's starting from 0, or maybe his teeth are a little bit misaligned anyway, which is very normal. So before I measure side to side, Jack, I'm just going to get you to smile, and I'm just going to be popping this ruler up against your teeth, okay? So just smile, just normally, nice wide teeth, teeth together, good. You can see his lip is in the way, so I'm just going to pull his lip down just so I can see that line on the bottom teeth. And his lines up really nicely anyway, but if that was off to the side, like let's say his bottom teeth, that middle line wasn't lining up with the top one, I can be establishing what that overlap is as a baseline. So then if I'm measuring laterotrusion, I'm going to get you to move your jaw as far to the side as possible. Perfect, and then he's already moving his lip out of the way, so then I'm just going to be measuring again that middle line of the top teeth to the middle line of the bottom teeth. What we might often see when we try and measure this movement is that they open and laterotruge at the same time. So if they're doing like we're wanting to cue that patient just to keep your teeth close, and I just want you to move straight to the side, not open your mouth. The other thing that we might be measuring is protrusion range. So for this one, we're coming more to the side, and again, we need to be establishing the baseline for this patient. So for protrusion, remember we've already had a look at whether they've got an overbite or an underbite, but that's going to affect our protrusion-retrusion measurement. So Jack, I'm just going to get you to smile again, just teeth together, smile normally, good, and I'm just going to move, yep, teeth together, good, big smile, great. And then I'm just going to be getting a measurement of how far forward his top teeth are from his bottom teeth. And if the plint's a little bit lower, I can be seeing that on the ruler. If you're a little bit unsure doing these measurements, sometimes it's nice at the start where you line it up and then you can just use a little marker or something like that on this. Make sure you're not drawing on the patient's teeth. So I would just be getting a little marker and just doing a little nick across there, and then I can take it away and measure it. And then, so now we're going to be measuring your jaw going forward, okay? So I want you to move your bottom teeth forward as far as possible. Good. And then again, I'm going to be getting that measurement from the top teeth all the way down to the middle of the bottom teeth, okay? When we're recording that, if I'm just using it as a reassessment for Jack, I don't really mind. His overbite, underbite probably isn't going to change a lot. His overlap in the teeth with the laterotrusion probably isn't going to change a great deal from visit to visit. So you could just record those values that I've gotten for Jack. If we're wanting to compare to normative, or if we're doing anything like, let's say he's got a problem with the protrusion movement, I might want to be recording that so that I'm saying, so for example, if he's moved forward 5 millimeters, but he's starting back 2, so he's got an overbite of 2 millimeters, he's actually got a protrusion range of 7 millimeters. So it's 2, which is bringing us to 0, and then it's 5, which is what I'm measuring with the ruler. Exactly the same with laterotrusion. So if we're measuring from the side and he's starting at 2 mil off to the, for example, the left, when I measure him going to the right, I want to do, let's say, 10 mil plus the 2 that he's starting from, because I'm just measuring from his 0, but he's not starting at 0. Normative ranges for side-to-side movement, again, these can vary a little bit. So side-to-side, typically we're expecting about 10 mil, but we'd definitely be comparing side-to-side. Most people are going to be 12 mil or less. If they're getting a lot more, again, we want to understand, is that normal for them? Is it potentially a sign of hypermobility? And maybe we need to be thinking about other hypermobility scales like the Baton scale. Are they hypermobile? Are they floppy everywhere? For protrusion range, typically we don't get as much movement with that. Again, it kind of falls between that 5 to 10 mil range. Definitely anything more than 10 mil, I'd be saying is starting to be a bit, is that normal? Or is it a sign of potentially hypermobility? So when it comes to measuring retrusion range of motion, to be honest, we don't measure this a lot clinically because we're not going to be getting much movement. It's the space of 1 mil or 2, and that's usually the degree of margin of error that we get with a ruler measurement anyway. So just to demonstrate, so Jack, if I just get you to smile, just normally let us see your teeth. Good, I'm just going to move this lip out of the way. So you can see he's already sitting in a slight overbite position anyway, which is normal. And then I'm just going to try and get you to pull your jaw or your bottom teeth back. Yep, perfect. So you can see, now just smile. So he's not really getting much movement there at all. That's pretty normal. So if that's the case with retrusion, I'm just going to observe that rather than measure it. Most people, when they're having problems with moving their jaw, the most affected movements that we'll see, particularly for people that are getting clunky, locky jaws, are those with opening and those with protrusion. What happens at that jaw joint during those movements, we've got the condyle on the skull, and then we've got the mandibular condyle that articulates in that little cave. As you open your mouth, that condyle on the mandible is going to rotate and translate anteriorly. The disc sits on top of that like a little hat, and it should be moving in a coordinated manner with that condyle. So if there's a disc problem, often we'll see it when they open up their mouth because that disc is getting stuck or it's relocating and dislocating. Or it's when they protrude, which is when they're getting that translatory movement. So often in an active range of motion assessment, If they're having disc problems, for example, so those that are mechanical jaw problems, we'll see when they open their mouth, as that condyle is starting to translate forward, they're reporting a clunk or a click or whatever with that. So we've observed active range of motion of the jaw. We've also measured active range of motion of the jaw. The last thing that we're going to do is feel what's happening at that TMJ as he's moving in each of those directions. So Jack, I'm just going to put my hands on your jaw joint just so I can feel what's happening as you move, okay? So I can feel for the arch, the cheekbone, and then if I come slightly inferiorly from that and I just get you to open and close your mouth a few times, good, I can feel those mandibular condyles under my fingertips. So that's what you're wanting to be on, and both sides, that's really important. So what I'm trying to think of as he's moving is, again, I'm trying to build this picture of what's going on with his jaw during movement, and how does that link in with what he's reported he's experiencing and what he's having problems with. So, Jack, I'm going to get you to open your mouth as wide as you can again, good, and then close. So from this position, I should be able to feel the rotation stage with the condyles and the translation stage. So Jack, if you just open halfway and then close. So that's his rotation stage. Predominantly, you're getting a little bit of translation, but the predominant movement is that the condyles are just doing this in the jaw joint. So if you just open halfway, good, and then close. And I'm just checking, does it feel like they're moving relatively symmetrically? Then I'm going to have a think about the translatory stage. So Jack, I'm going to get you to open your mouth as wide as you can, and the translatory stage is when you really feel those condyles sliding forward. They'll become a lot more prominent under your fingertips, and then close. Good, and open. So if somebody's having a problem with disc movement, so their temporomandibular disc might be sitting too anteriorly to begin with, when that condyle starts to translate forward, what we'll often feel with those that have a relocating disc is that they get to that translation and we'll feel a click. And that's that disc often coming back onto that condyle. So I might feel that on just one side. It's less common that you'll feel it on both, but you definitely can. And I'm getting an idea of what part of the movement I'm feeling that click happen. Quite often it's going to be that halfway. I'm also wanting to marry in what I saw from the front during mouth opening with what I'm feeling through the back. So for example, if Jack was opening his mouth and deflecting to the right, so his jaw is swinging off in a J shape to the right side, what I might be feeling from the back is that when he opens his mouth, the right side, the right condyle's not translating forward the same as the left. So it's creating this swing happening at the jaw joint instead of both sides opening equally. So just one more time, open your mouth as wide as you can, good, and then close. So I'm checking for that symmetry side to side, and I'm marrying in what I saw from the front with what I'm feeling happening in those joint articulations at the back. I also want to be having a look at side to side movements. So Jack, can I please get you to move your jaw as far as you can to the side? Good, and I'd say the right or the left, and then back to the middle, and then as far as you can to the other side. Other way. Yeah, good. And then back to the middle. And I'm, again, wanting to get a bit of an idea of when he's moving this way, are his condyles moving the same amount as when he moves to the other side? So we're checking that condylar symmetry. We're going to have a look with protrusion. So again, protrusion is another really common one that's affected in people with disc problems. So when you move your jaw forward as far as you can, I'm really checking that translatory stage. And again, that translation is often problematic if that disc isn't articulating in a coordinated way with the mandibular condyle. And you can, again, check retrusion, so just pulling your teeth back as far as you can. But really, you're not going to be feeling a whole lot with that. Good. So now we've had a look at jaw movement, we've measured jaw movement, and I've had a feel of what's happening with his jaw when he moves without changing anything to do with his posture. The next thing I want to do is a bit of a TDT, so a treatment-directed test, and it's going to help me understand how much involvement from the cervical spine, his postural component, might be influencing his jaw problem. So in this part of it, what I'm going to be doing is just trying to change his posture, get him in more of an upright position, and then reassess those movements that he was having problems with. So let's say Jack was, when he was opening his mouth, he couldn't move his mouth as far. We might have been seeing a deviation with it, and he was reporting a click when he moved. What I want to do now is going, okay, Jack, what I'm going to do is I'm going to get you to sit up nice and tall. Good, so up through the middle of his back, chest nice and wide. Good, like there's a string coming out the top of your head. Perfect. So we're getting him in a lot more of that upright position, and then I'm going to be reassessing that problem movement or movements. So Jack, now what I want you to do is open your mouth again as wide as you can, and I want you to tell me if it feels any different for you, okay? Good, and then close. So I'm again observing to see whether there's been any change to his, for example, deviation or deflection, see whether he's reporting any change to his click, his clunk, his lock, and I might be measuring that movement to see if we can get any further. If I'm seeing a significant improvement, so let's say we sit him up nice and tall and suddenly he can open his mouth significantly further and he's not reporting a click anymore, I already know within the rest of my physical examination, I'm still going to be having a feel around the jaw, but I need to be diving in pretty heavily into what's happening in the cervical spine and even down in through the thoracic and the shoulder girdle. So my assessments might be a little bit more targeted towards, for example, manual assessments of cervical and thoracic spine, my pivums and my pavums. I might be looking at passive range of motion assessments of the cervical spine. I might be having a look at shoulder girdle and shoulder range of motion, as well as muscle activation around that shoulder girdle. So for example, a prone scapular hold or his internal-external rotation. So that's going to be in my initial assessment. If I notice a really big change in his symptoms, I'm not actually doing anything to the jaw in this position apart from changing its starting position and how it might move from that point. So the last thing that we're going to do with an active range of motion assessment is, particularly if we're noticing that the cervical spine or below might be having a big involvement, I might want to get a more standardized measurement of Jack's jaw movement without so much of the functional involvement from the other areas. So I just want to know what his baseline is and make it really easy for me to reassess that between sessions. So in this position, I'm going to line Jack up against the wall. So he's got the wall for support. I want his head to be against the wall, but with him in a neutral position. So you can see in this position, he retracts quite a lot through that upper cervical spine to get there. So I'm going to put a pillow or a towel, behind his head. And then I'm just going to use this as his standardized position to be getting some jaw measurements as well. And in this position, we can be measuring, as we did up on the plinth, we can be measuring jaw mouth opening range of motion, side to side, so laterotrusion, as well as protrusion range of motion, so that jaw coming forward. So now that we've finished up our active range of motion assessment and we're already starting to have a think about whether the cervical spine and below is involved in this person's jaw problem or not, we're going to get our patient into a supine position and start to look at our extraoral, so on the outside of the mouth, as well as intraoral assessment of the jaw. So in this position, I'm going to start off just with a very general feel of what's going on. I'm checking for things like heat and swelling. So Jack, I'm just going to be having a feel of some of the structures around your jaw. I just want you to let me know if you're getting any pain or discomfort when I touch these, okay? So I'm just going to start very broadly with the back of my hands, just feeling around that jaw joint, as well as down along the mandible. I'm going to then kind of be assessing for heat or swelling with that. Then I'm going to be starting to have a think about my specific palpation of structures. And this is going to be a really helpful part of the exam to figure out what might be contributing to his jaw problem from a structural point of view. I'm going to start around the temporomandibular joint, so that TMJ. And one way that I can check whether I'm on it is, Jack, can I just get you to open your mouth, good, and then close. And again, I can feel those condyles under my fingertips. So I'm going to be having a feel of that TMJ. I'm going to be comparing and seeing if he reports any pain on one side compared to the other. So for example, if he's got right-sided issues, I'm wanting to know, is that any more painful on one side compared to the other for you? So I'm having a feel through the TMJ. You can also be feeling, by palpating the TMJ, we're palpating the joint capsule around it as well. So you can be getting an idea of any thickening or tenderness around there. I'm then going to stick with my palpation of bony structures. So I'm going to palpate down along the line of the mandible and then coming all the way forward. Just checking there's no kind of pain or discomfort along there. Again, we're kind of thinking of symmetry. So does that angle of the mandible feel similar on side to side? From side to side. We can then be palpating up through the cheekbone. We can be palpating up onto that temple as well from a bony perspective. The next thing that I will want to do, and this is really important for people that from the subjective and the objective examination, we're thinking they might be reporting or might be experiencing more of our pain-related TMDs, and potentially that pain source is coming from some of those muscles of mastication. So particularly those muscles that are working really hard when we clench and grind. So for this, the two big ones that we're going to be feeling on the outside are masseter, so coming down through the cheek, slightly inferiorly from the TMJ. And if I want to check if I'm on it, I just want you to clench your teeth together and you'll feel that pop up and then relax. You'll feel that pop up and see it pop up really nicely into my fingertips. So I'm wanting to feel through that masseter all the way from the kind of the proximal attachment all the way down onto that mandibular attachment. And I'm checking for any pain reproduction. I'm wanting to kind of feel, do they feel symmetrical, or does one side feel, for example, tighter or atrophied on one side compared to the other? And again, how does that marry in with the symptoms and the problems that he's reporting? So for example, if he's reporting right-sided pain, I've already established that he's a clencher, he's a grinder, his symptoms are really aggravated with those kind of closing activities, including stress and sleep when he's clenching and grinding at night. I might actually expect to notice hypertrophy of his masseters, and he might report a familiar pain when I palpate it on his affected side compared to his unaffected. And familiar pain is important. Comparatively, if he is, for example, experiencing intra-articular TMDs, so maybe he has degenerative joint disease like osteoarthritis on one side, or he's having disc issues on one side that is affecting how he uses his jaw, we might actually feel atrophy on one side compared to the other, and he might still report pain with that. So we need to be getting an idea of how that marries in with his symptoms. So masseter, then we're going to come up onto temporalis, which is the other major clenching muscle. So we find that cheekbone, we come superiorly from that. And if I just get you to clench your teeth, good, and then relax. And so your temporalis is a really big fan-shaped muscle on that temple, and I'm just coming up and again checking for symmetry side to side and checking for any symptom reproduction. So masseter, temporalis. From here, I can also come down and palpate the back of the jaw. So I'm feeling that vertical part of the mandible, and I'm palpating along the back of that. This is a pretty sensitive area for a lot of people, particularly if they're reporting jaw problems. You might find one side is more sensitive than the other, but we need to be making sure that it's a relevant finding and not just because it's a sensitive area. So just be careful with your palpation, and if they're reporting symptoms, we need to be going, is that a familiar pain to you or a familiar discomfort to you? Does it marry in with what they're reporting? So we can feel the posterior part of that mandible, and then we can be coming down. So from the angle of the mandible, if we're then tucking up underneath it, that's going to be your suprahyoid muscles through there. So we've got your mylohyoid, your geniohyoid, your stylohyoid, and your digastric muscles that sit under this mandible and attach onto that hyoid bone really high up at that front of the neck. And these muscles are really important for mouth opening as well as for movements like swallowing. So again, checking for symmetry, tension side to side, or any reproduction of pain. In this position as well, I would also be palpating the cervical spine. So I'm going to come back posteriorly and have a feel of that upper cervical spine in particular, the suboccipital muscles through here. I can be coming around to the side of the neck and palpating down through scalenes and even through sternocleidomastoid and some of those anterior cervical muscles. The next thing we're going to be doing in our physical assessment is having a look at observation and palpation intraorally. So there's a number of structures and there's a number of hints that we can get of what that person is doing on a day-to-day basis on the inside of the mouth that we can't see and capture if we just do an extraoral assessment. So for this, I'll talk you through in a minute with gloves on what I'm looking at and what I'll be palpating on the inside. Before we do that, I might just talk you through and just do a little bit of an anatomy refresher because some of these are a little bit hard to see when my hands are in the mouth. There's going to be two main muscles that we will palpate intraorally that's really hard or we can't access on the outside of the mouth. So these are going to be your medial and your lateral pterygoids. And you should remember from earlier I was saying these pterygoids, especially lateral pterygoids, are really critical to disc movement around the jaw because they have attachments onto that mandibular condyle, and there's theorized in some people it attaches onto the disc as well. So it helps that disc move forward and back. So the lateral pterygoid muscle attaches here to the inside of this condyle bone. The medial pterygoid is a lot more vertical, so it's kind of a similar orientation to your masseter muscle, and it attaches through here and then comes down and attaches around that angle of the mandible. So you can imagine both of these are very difficult to palpate extraorally, so we need to be getting inside the mouth to be having a feel. We'll pop a gloved finger on. The landmarks that I'll use to orientate you are the teeth and then this edge of the mandible, so it's the mandibular ramus. So when I do the intraoral palpation, we'll be coming inside, so you're outside the bottom teeth, and then you're coming back and finding this vertical ridge on the ramus. So when you get to that, I want you to go outside the teeth but inside the ridge, and then you're going to be hooking your finger up and trying to get right up high near that TMJ. So when your finger is hooked and it's kind of hooking up towards you, that's us trying to palpate that lateral pterygoid. you might notice, and it's definitely not diagnostic because we have structural differences person to person, but you might notice if they're tight on one side, they'll often report more pain on palpation. You might also feel like there's less room for your finger on the side that's tight. So when we're trying to palpate nice and high up around that lateral pterygoid, it'll feel like there's less room for your finger up in that area. For medial pterygoid, because it attaches down here, I'm going to actually keep my finger in a similar position, but then I'm going to kind of rotate it, and you can be scooping down through the medial pterygoid and more palpating that distal attachment. So now we're going to move on to our intraoral assessment. So in our intraoral assessment, we're going to be popping on some gloves, and then we're going to be having a look at observation of structures within the mouth, palpation of a few key structures in the mouth, and then performing some joint glide, so a joint glide assessment of the temporomandibular joints within the mouth. So for this, from an observation perspective, there's a few key things that we might be looking for that particularly tell us whether this person might be clenching or grinding and using their jaw abnormally in day-to-day life. The first thing that we're going to look at is the tongue. So Jack, can I please get you just to poke your tongue out? Good. And then I'm just looking at the side of the tongue. We're looking for something called scalloping. So you can see, I'm just going to grab your tongue, sorry. So you can see there's little indents in people that are thrusting that tongue forward to rest on the teeth. We will often see that scalloping pattern on the side of the tongue. And that's already making us start to think perhaps they're not sitting with that tongue and that jaw in an appropriate resting jaw position, and that might be something that we target within management. So the next thing that we're going to be looking at is the cheeks. So with the cheeks, we're looking for signs that they might be biting down, clenching, or sucking their cheeks at rest. The biggest sign with this is that when we look at the inside of their cheeks, we're going to see that line or that ridge around where their teeth would sit. So for this, I'm just going to get you to open your mouth. Good, just relax. And then I'm just pulling it aside and having a look to see. So Jack definitely doesn't have any cheek chewing signs. In some people, you might even see ulcers or sores from them biting down so much. But often we'll just see a ridge along that cheek where they kind of suck it or chew it between their teeth. The last really key sign that we're looking at from an observation perspective intraorally is wear along their teeth. So we've already had a look with Jack in a functional position where those teeth are sitting or lining up on each other. What we're having a look at now is signs of them grinding or clenching their teeth. A really key area that we'll see this is on the pointy teeth. So instead of being nice and pointy, you'll see that they're just flat, they're worn away. And that's from that person moving their jaw side to side a lot and clenching down while they do it. So can I just get you just to smile? Good. And I'm just looking at his incisors or at his pointy teeth and having a look at whether it looks like they're flat from him grinding or whether they're still relatively pointy. So often it's a combination of those factors. If I'm observing somebody's tongue, cheeks, and teeth, and they've got all of those key signs of a clencher grinder, often they'll be doing it even if they don't know that they are. And that might be something that you want to address within management. Okay, the next thing we're going to be doing is moving on to our intraoral palpation, particularly of our lateral pterygoid and our medial pterygoid. So for this one, Jack, I'm just going to be popping my finger in your mouth. I'm going to be feeling right up high at some of these muscles up around your jaw joint. They can be a little bit uncomfortable, but I'm going to be comparing side to side, and I want you to let me know if one's a bit more sore or tender than the other, okay? So just open your mouth, good, and then relax. So remember, we want that jaw relaxed because if his mouth is open, that condyle's going to be really anteriorly positioned, because he's going to have that anterior translation, and it's going to be really hard for me to get my finger up into that lateral pterygoid space. So I just get him to open his mouth, pop my finger inside the mouth, and then get him to relax. The next thing I'm going to do is follow that line of the bottom teeth along until I feel that bony ridge. So that's the mandibular ramus as it translates, or as it starts to move vertically. So following the line of the teeth along, reaching that bony ridge. Now I want to go inside the ridge but outside the teeth, okay? Once my finger's inside the ridge, outside the teeth, I'm then going to be creating a little hook with my finger and hooking that up so it's kind of facing up towards me. So I can follow that ramus up and along. So my finger is kind of positioned like this on the inside, so running up the ramus towards the TMJ, and then I'm going to have my finger kind of hooked up in towards that space. So it can be a pretty tender area. We just need to make sure that we're not kind of pushing too hard. Make sure that you're pushing with the pad of your finger and not your fingernail. And then I'm just going to be getting an idea of any pain or discomfort, particularly if it's familiar in that position. Then I'm going to be coming down, so if I'm palpating up really high for that lateral pterygoid, so my finger's kind of up like this. For medial pterygoid, if I'm wanting to feel more distally, which is the easiest part to palpate, I'm just going to keep my hand in the same position, but turn the hook. So I'm kind of palpating more down towards that angle of the mandible. So I'm going to rotate down and palpate up along so I can kind of follow that ridge down towards the angle of the mandible. And that's going to be more your medial pterygoid. If you were too laterally, so if you haven't come onto the inside of that ridge for these, what you'll see is when you're palpating laterally, you can see my finger moving on the cheek. That's actually going to be your deep masseter fibers. So if you're wanting to palpate masseter, the deep fibers, we can be coming on the outside, putting my thumb so that I'm kind of resisting it, and then I'm just moving that masseter against my thumb. So if we're palpating on one side, we always want to compare to what it feels like on the other side, so we can establish whether that's a positive finding, whether that's relevant to what he's come in with today, as well as help to direct what we're feeling. So like I said earlier, for lateral pterygoids, we're comparing his pain reports on the left and the right, but then I might also be just subjectively thinking, does it feel like there's more space for my finger on one side compared to the other? And often if lateral pterygoids is tight, it'll feel like there's less room for my finger on the side that he's tight on. Medial pterygoid, same thing, is more tenderness, and then I'll demonstrate masseter on this side as well, that deep masseter, and how that differs to medial pterygoids. So if you just open your mouth again, Jack, I'm just going to be doing the same thing on this side. So finger in the mouth, following the bottom line of teeth along till I reach that bony ridge. Then I'm coming inside the bony ridge, staying outside the teeth, following that bony ridge up, and then my finger is hooking up almost towards his kind of eye area. That's the angle that I'm aiming at for it. So that's going to be his lateral pterygoid. I'm comparing the space side to side, and it should feel like my finger's in like a little bony nook. As I slide down to medial pterygoid, you'll notice that I'm rotating my finger, and then if I'm coming out to laterally, I'm going to be on that deep masseter. So with this one, you'll see on the cheek, you can see my finger there. If you're trying to palpate medial pterygoid and you can see your finger through his cheek, you need to be getting more medial, so inside that ramus. For masseter, I can be palpating deep masseter, so we've already palpated extraorally. Deep masseter, I'm just using my thumb as a bit of support on the outside, and then I'm just rolling my finger on the inside, those deep fibers of the masseter, and feeling, tension, atrophy, pain reproduction, or symptom reproduction, one side compared to the other. Now we're going to be moving on to our joint assessment. So we're assessing for hypermobility of the TMJ on each side, and then we're also assessing for symptom reproduction while we're doing this glide. So 2 glides that we're going to be doing intraorally are our distraction glide. So I'm going to be trying to distract or pull apart, I guess, open up this TMJ, move the condyle away from the skull. The other one that we're going to do intraorally is a lateral glide, and I'll show you on the skull in a minute where my hands are going to be. So for a distraction glide in assessment, I want to be palpating with one hand that joint line so I can assess what is happening at that joint. So just open and close your mouth, good, and then relax. So I'm sure that my fingers are right over that joint line near the condyle. My other one for a distraction glide, I'm going to run my thumb along the teeth, so move to the back, make sure you stay on the teeth and that your finger's not inside there, because a lot of people are kind of sensitive towards that back of the tongue and throat area. So thumb stays on the teeth, and then I'm just going to be trying to pull that back of the teeth away from this finger. So I'm kind of pulling it towards his feet. So just open your mouth, good, and then just relax, good. On the outside, I'm using my fingers on the outside to get a good hook around that mandible, so I'm really able to get a good control over that bone that I'm trying to move. This hand is just palpating. So Jack, I'm just going to be pulling down on your teeth. Let me know if you get any pain or discomfort. It should be pretty comfortable. Just relax your mouth, good. And then I'm just going to be pulling, so the pressure is all through the back or the top of my thumb, and I'm trying to pull that back of the mandible down towards his feet. The biggest mistake that people make with distraction is that you're pulling with the base of your thumb, like at the front of the mouth. What you'll see if you do that is that you're just doing P-ROM of mouth opening. So and then just relax. If I'm pulling with the front, I'm just going to be opening his mouth. We're wanting a distraction. So you need to be pulling with the tip of your thumb down, and then you're going to be feeling at this finger a little bit of gapping or opening up around that joint line. The next one that we're going to do intraorally is a lateral glide. So in this position, I'm going to be standing on the opposite side of the bed, palpating that joint line again, and then I'm going to be getting on the medial aspect of the mandible. So if I'm doing a lateral glide, I need to be, it's a lateral glide of this joint, but it's actually doing a medial glide of this joint, okay? And we'll look at this in a bit more detail in treatment. So just open your mouth, good, and then relax. So my thumb is, again, hooked. My thumb is on the medial aspect of the mandible. My fingers are hooked around the jaw, and then I'm just trying to pull that jaw laterally, so towards this way, okay? And again, I'm assessing any movement, so hypo versus hyper compared to the other side, and any symptom reproduction that he might be reporting. Okay, so just so you can see where and appreciate where my fingers were inside the mouth with those joint glides and what we're trying to achieve at the TMJ, I'm just going to demonstrate on this skeleton to hopefully make that make a little bit more sense. So on the outside, my hand is palpating this TMJ joint line, okay? With the moving hand, for a distraction glide, I want my thumbs on top of the molars, so it's between their teeth. My hand is going to wrap around that mandible, so I'll just hold down here just so you can see a bit better, but in reality, I'm gripping onto that mandible around there. What I'm going to do with the distraction glide is I'm trying to bring this bone away from the skull, okay? So under my finger, I should feel a gapping happen with that. You'll notice if I, relocate that jaw, if I was doing more through the front of my hand, first of all, you'll notice the mouth is opening. Second of all, you'll notice that there's no distraction movement happening here. So it's really important that we're trying to pull from the back of the teeth. For a lateral glide, I'm going to come onto the medial aspect of the mandible and grip around that mandible again, palpating the joint line. So for this one, I'm trying to move this left TMJ or this mandible to the left for a left lateral glide of the TMJ. It's also important to appreciate that when I'm doing this, it's also doing a medial glide on the right TMJ. So just make sure when you're talking to your patient and getting an idea of what they're feeling during it, clarify which side they're feeling it on, because sometimes they'll feel it on the other side. The last thing that we're going to be doing as part of our jaw assessment in the objective examination is going to be doing a PA glide. So this completes our jaw joint assessment. So we do this extraorally. You can find that TMJ, so I'm palpating this side, but again, important to remember that it is having an effect on the bottom side as well. Jack, can I get you to get your bottom hand and just rest it under your face, please? The bottom hand, yeah. Cool, so often that is nice and comfortable to the patient, just helps to give that bottom TMJ a little bit of support as well. So a PA movement, arthrokinematically, is linked up with the translation component that they get during opening. So for this, I'm going to be palpating the joint line with this hand. And Jack, if you just open them out, yep, good, and then close. So I'm just double checking that I'm over that joint line. This is a really tender spot, remember, at the back of the jaw joint. So we just need to make sure that our thumb is kind of on bone as much as possible instead of just pushing soft tissue in the back onto the back of the mandible. That'll be really uncomfortable for the patient. We're also not needing a great degree of pressure with this one. So we're just trying to assess any of that PA movement that's happening at that TMJ. So Jack, with this one, I'm just going to be having a feel of what's happening at the joint. I'm just going to be gently pushing forward with this hand onto the back of your jaw. And I just want you to let me know if you're getting any pain or discomfort as I'm doing this, okay? And at this joint, I'm feeling that condyle move forward as I push. I find making like a little gun shape is helpful just because my index finger is pointing where I want that jaw to go. So for a true PA movement, I'm going to be pushing towards his lips, okay? You can assess these in varying degrees of jaw opening. So if I wanted to get him to open his mouth a little bit, I might just be adjusting what position or what angle I'm pushing that jaw in slightly. But in a closed mouth position for a true PA, I'm going to just be pushing directly forward. So the very last thing that I'm going to demonstrate in this practical as part of the objective examination, especially in those early days, is going to be an assessment of muscle function. We're specifically going to be looking at muscle function of the closing muscles, so temporalis and masseter, and we can also be checking for activation of muscles like the hyoids, so the suprahyoids and the infrahyoids. For masseter and temporalis specifically, I wouldn't be doing this assessment in everybody that comes in on day one. So especially if we're from the patient interview and the physical examination, we're starting to build this picture and think that maybe this person's problem is that they're clenching and they're grinding a lot, and they're not reporting necessarily any problems when they're biting and chewing, and it's more with mouth opening. I might actually not be doing early on an assessment of some of these muscles to look at timing and strength, because I think their problem is that they're using these muscles too much. And within management, I might not be prescribing an exercise program that's going to help coordinate these muscles during clenching and biting movements. For this, we need to be considering that muscles work differently through different ranges of mouth opening and also with symmetrical versus asymmetrical loading patterns. So I would start with, if we're assessing masseter and temporalis, I'm going to start just by palpating, for example, masseter, and then I'm just going to get you, Jack, just to clench your teeth together, and I'm just feeling for timing. So, and now just relax. Good. Now, can you please do that again? So clench your teeth together. Because he's clenching symmetrically, his teeth are together, I should feel them firing at pretty much the same time and pretty much the same amount. So if we're starting to notice that one side, you can relax, thank you, that one side is a lot slower to come on, or they come on at the same time, but then one side drops off really quickly, that might be something that we're starting to think about we need to address within management. We can be doing the same for temporalis, so just clenching your teeth together, good, and then relax. And I'm just checking again for symmetry of activation, both the timing and the amount. For suprahyoids in particular, and infrahyoids will work at the same time as well, I can be palpating under the chin, and I can get, so Jack, can you please just push your tongue into the roof of your mouth, and I'll feel some of those muscles switch on. The other thing that I can be doing is just providing a little bit of support to the cervical spine, and then I'm going to be resisting under the chin and getting you to open your mouth. Good, and then just relax. So it's kind of like a symmetrical mouth opening loading pattern, which should be getting his hyoids on. If that's okay, so let's say you've assessed masseter, temporalis, in this position, they feel pretty symmetrical, but he's reported in his patient interview that he gets a lot of clunking when he chews on one side of the mouth. We might then want to have a look at his loading patterns in a more mouth open position and or with asymmetrical load. So that's where paddle pop sticks or even a cork can come in handy. I'm going to use paddle pop sticks today. I've got 3 here, but you can go wider or smaller depending on where they're reporting issues. Generally speaking, the more open their mouth is, the harder it is for them to be using these muscles. So it's the same as other areas, the more kind of outer range they're getting, it becomes difficult compared to more of those mid-range positions. So Jack, can I please just get you to pop that between your molars on this side? Yep, just kind of like where you would chew a nut or something like that. You can hold on to it if you like. And now I'm going to be doing the same thing. I'm palpating masseter, so I just want you to bite down onto those sticks, and I'm feeling for activation side to side. I can be doing the same with temporalis, and then I can also be palpating the TMJ to see if it reproduces any of his clicking. Good, and then take that out. If I wanted to assess mouth, I wanted to assess symmetrical loading in a more mouth open position, I would just be getting the same number of sticks side to side. So functionally, a lot of the patterns that we struggle with are the asymmetrical loading in a mouth semi-open position. So for example, if he's got a bit of steak between his teeth on this side and he's biting down, he needs to be able to coordinate the left and the right side to support that joint during that loading pattern. So based on what we've just found within that muscle function assessment, that might help to direct some of our management priorities as well. It is really important that we consider where these kind of tests might be relevant. So if I had a patient that had a really irritable jaw, I probably wouldn't be doing these tests day one, or in somebody that is a big clencher grinder, we're not going to be giving them exercises that are going to be loading these muscles. So important to consider whether that's relevant, what kind of information you're getting from this for this patient. It's one of the reasons I'll often do these assessments at the end as opposed to at the start with all the other sitting assessments, but there's some patients certainly that I wouldn't even look at this within the first couple of sessions. So thank you for listening. That concludes my practical on the assessment of temporomandibular disorders. A couple of key take-homes from the practical today. The first thing is seeing, first of all, whether it's a TMD or potentially something else, or seeing if there's other contributing factors to the TMD. So we need to be considering the close relationship that the jaw has with dental as well as with the cervical spine. The second thing is that impairments with TMD often span a number of different domains. So often we'll see range of motion, we may see proprioceptive or motor control impairments, and we may see muscle function impairments as well. So we need to be making sure that we're conducting a really comprehensive examination at the start. And then lastly is that we need to be making sure that we're considering both sides of the jaw and how they work together in a functional pattern for these people in day-to-day movement. So we need to be making sure that we're asking about both sides and then exploring how movement at one or impairments at one may be influencing impairments or movement at the other as well.
Well, hi everyone. My name is Sarah and I help run the Q&As for Physio Network. I'd like to start by welcoming Alana Dinsdale, who is here today to answer some of the questions that have been submitted about her fantastic practical on TMD. So, welcome Alana, and thanks so much for joining us, and I hope you all enjoy tonight's session.
Thanks for having me.
We will kickstart with the first question. And the first question is, if the lateral movement is reduced to one side, what does that indicate? And during protrusion, if it deviates to one side, what does that indicate?
It's a really good question, and I think as part of the observation of mouth opening, it's a pattern that we do see quite a lot, is that they might swing to one side. If they're swinging to one side consistently, so let's say we're talking about a deflection, so where they swing to the side and stay out to the side throughout the whole movement of opening, I'm probably thinking it could be one of three main things. It could be joint restriction on the side that they're swinging to. So whether there's something going on within the joint, like a disc issue, that disc being displaced anteriorly, or it could be a capsular or ligamentous problem. It could also be muscle weakness of the side-to-side movers or tightness of the side-to-side movers. So we're kind of thinking lateral pterygoids, medial pterygoids. So if I was opening and I was swinging off to the right, for example, I could be thinking maybe my lateral pterygoids or medial pterygoids on the left might be tight or working a lot harder or more than the ones on the right side. Equally, the ones on the right could be weak, for example. So it's causing that, I guess, imbalance between the two sides that causes the swing. Whereas when they were working symmetrically, we'd expect much more of a straight movement. So really it could be any of those three things. If we're seeing more a deviation, so they're swinging out to the side and then they scoot back into the middle, that's probably when I'm starting to think there might be those motor control issues. It could be muscular issues through range, or things like a disc problem that maybe it's that disc is relocating and that's why they're recorrecting back to the midline. So yeah, does that answer? And I guess during protrusion, I think that was the second part of the question. During protrusion, to be honest, protrusion, they don't get a lot of range with anyway. So I would say it's probably less common that we'd see the swing to the side during protrusion compared to mouth opening. But certainly it could be for the same problem. So it could be that if, for example, they're trying to protrude and they're stiff or restricted within the joint or joint structures on one side, it could cause it to swing towards that side because it's not translating properly. Equally, it could be, again, if the pterygoids were, one was working a lot harder or one was a lot tighter, it could be also causing that side-to-side movement of the mandible.
Fantastic. And I suppose that's where you'd go into your assessments further.
For sure, yeah. So it's really kind of like other areas of the body, the active range of motion assessment and any functional assessments are really, really helpful starting points to kind of direct or guide the rest of our physical examination.
Fantastic. Thank you. And then the next question is, do you generally do all of your active range of movement assessments every time during your initial assessment?
So every initial assessment, yes. So I would always, even if they don't report a problem with opening, I would always still be looking at opening. It's incredible the number of times that sometimes actually when we start digging in, it's different to what we are thinking about when we've finished the patient interview. So absolutely, I always run through the active range of motion of the jaw and the neck in every initial assessment. And then my subsequent assessments generally focus more on repeating those measures that I found impairments in. So if they've got normal mouth opening, I might still check it in future ones if I'm expecting my treatment to have some kind of effect on, range or movement through range. But typically I tend to prioritize those that I've noticed a problem in the initial.
And I'm curious myself, in terms of your description, I know you've spoken about in terms of opening, you can have the measurement, but when you're giving the qualitative description of whether the jaw is deviating or there's that sort of relocating moment, are you describing that in your notes as exactly that, just qualitatively what it's doing?
Yeah, so usually if I'm thinking about how I would record my AROM assessment of the jaw, I might say opening, then I would record the measurement that I get, so their total active opening range of motion. And then I would always describe the quality. So I might say that they move straight, I might say they deviate consistently to the right or to the left, or they deflect, or they demonstrate inconsistent movement patterns, upon repeated opening. So definitely. The other thing that I would always report or document as well is any joint sounds that either I feel or notice, potentially I can hear it, or when I do my palpation, as well as anything that the patient might report. Sometimes they go, yeah, there's a bit of a click there, but we put our hands on and we're like, oh, it doesn't, it's maybe more like a crepitus, or it might be a very, very faint clunk that happens through range. So I would be reporting that as well, definitely.
Fantastic, thank you.
Okay.
Question number 3, do you use muscle activation to help determine correct placement of your fingers when palpating? And if so, how do you cue both medial and lateral pterygoids?
Another great question. I use muscle activation a lot when I'm doing the extraoral muscles. So if I'm palpating masseter, temporalis, suprahyoids, infrahyoids, and obviously cervical spine, you can try and differentiate as well. But I would definitely around the jaw be using muscle activation to confirm the correct placement of my fingers extraorally. To be honest, intraorally, it's really hard. Because for a lot of people, there's not a lot of space for your finger anyway when we're getting up into lateral and medial pterygoids. So you can, depending on the client or the patient, I guess. So if I was palpating medial or lateral pterygoids ipsilaterally, I would be getting them to laterally or laterotrusion. So if I'm palpating the lateral pterygoids on this side, I want to be getting them to move their jaw to the side to try and get an ipsilateral contraction. If you could also do protrusion for lateral pterygoids, so that's when both sides are working symmetrically or at the same time. So either laterotrusion or protrusion for lateral pterygoids, and then laterotrusion or even getting them to clench sometimes for medial pterygoids is helpful as well. But like I said, I probably wouldn't use that as much unless I was really unsure that I was in the right spot, and then I might be trying to get them to do like an isometric contraction. But as soon as that, the mandible moves, there really isn't a whole lot of room for your finger.
Okay. And just to clarify, on the ipsilateral side with the lateral protrusion, is
Yeah.
that to the contralateral side? Or is
Yeah.
it more just the direction that you?
So if I was doing lateral pterygoids on this side, I would be getting my jaw to move this way because
Okay.
it's going to kind of pull
Contralateral side.
medially. Yeah,
Fantastic. Thank you.
that's okay.
All right.
It's all good questions though, because I think the intraoral palpation can be a little bit tricky to orientate and really be confident that you're on the muscle that you think you're on, especially lateral pterygoids. It's really high and really deep, so it can be a little bit tricky.
Which is where I think your videos are fantastic, because it's also just a matter of that familiarization, and the more we do it, the more confident and comfortable one gets with it, isn't it?
For sure. Yeah, definitely.
All right, question number 4. What are the common causes for people to develop issues with their TMJ disc?
This is also an excellent question, and I think it's probably one that I'm going to give the annoying answer of saying there are so many reasons, including almost what appears to be no reason at all. So there are definitely those people that they think occlusal patterns, so where our teeth come in contact with each other, plays a role, like the structure of our jaw, plays a role in risk factor for disc problems. Age is the other thing. So often disc issues, we're probably thinking often they're in more of that middle-aged to younger population compared to our degenerative joint diseases, which is more our crepitus. That's probably more your older generation, typically middle-aged to older. And females are typically more affected than males as well. The causes to develop it is really tricky. Some people report that their jaw has just always clicked, and then suddenly one day they come in and they go, I was yawning, or I had a dental procedure where my mouth was open for a really long period of time. Or they were eating cereal or toast or something chewy, and they just said that something happened, acute episode, and their jaw locked. And that's when we're probably thinking it might have gone from that anterior disc displacement with reduction to suddenly not reducing, where it's stuck at the front. And then there's those people that I guess have never had a problem, and then just suddenly one day they report their jaw starts clicking or locking. And then obviously there's the trauma group as well. So those that maybe have had a fall onto their jaw. I've treated a few people that have come off bikes and either broken their jaw or had a lot of disc issues because of that, and joint issues. And being punched in the jaw is another big one as well that we see, because often it's kind of that side movement that has a lot of problems, probably beyond just the disc, but they're ones that can definitely bring on jaw problems in that acute setting. So sorry, I can't give a more clear mechanism of injury because we don't really have that information at the moment. There seems to be quite an array of people that present with these disc issues.
Oh, I think that's a great answer. Sort of off the back of that, do you find you ask specific questions like chewing foods or chewing gum or those sorts of things to sort of see if there's anything habitual in their day that might be exposing it?
Yeah, I think as part of the patient interview, it's important to get an overall view of how people are loading their jaw in day-to-day life. So are they grinding their teeth at night? Do they clench their teeth a lot throughout the day through periods of stress? Are they, chewing lots of gum or hard chewy foods? But again, it's not as simple as saying that those that chew a lot of gum go on to develop jaw issues. So I think it's probably part of the picture, but it's one piece of the puzzle that comes in with everything else in that interview that really forms our diagnosis, and trying to figure out what's important and what's not to target within treatment, which can sometimes be a bit tricky, but I think if you, sorry, I'm bouncing around a little bit. Your chewing question prompted me, often when people come in and they do report problems chewing, I think an important question to ask is, are they getting pain or clicking or whatever when they're chewing on the side of their jaw symptoms, or are they getting it on the opposite side as well? There's a test that we do sometimes clinically called the dental bite stick test, and that is essentially getting them to bite down on one side, the contralateral side, and it's supposed to say, you know, if it's reproducing symptoms, it's suggestive of discogenic TMD. So I guess the side of chewing can sometimes help rule in or out disc problems compared to maybe muscle problems, which we'd expect potentially more if they're chewing on the side of.
Okay, so contralateral is more likely disc, ipsilateral is potentially hinting you towards muscular.
Yeah, according to that bite stick test, again, I think it's one part of the puzzle. So we always need to join that in with what we're seeing in observation of AROM, in their movement patterns, what we might be seeing in our manual examination and palpation. But it's probably one piece of the puzzle that might lean us more towards a disc diagnosis.
Fantastic, thank you. And we have a question from Mia. Thank you, Mia. What exercise guidelines do you recommend for post lower jaw surgery to improve mouth opening range of movement?
Mia, thank you so much for this question. It is an excellent one, and I would like to preface it by saying there really is not a lot at all in the space of exercise for TMD and post-trauma, and certainly in the way of exercise guidelines, at least that I'm aware of for TMD. So exercise guidelines, there's not really, it's probably more on a base-to-base with the surgeon, and communication with them as to what they're happy with you performing, what type of surgery they may have had, and obviously what stage they are post-op. The first thing that I would do is talk to the surgeon, see if there's any contraindications or precautions that they'd like you to be aware of, and then obviously using symptoms as a big guide as to how much or how far to push them.
That's a great response. Off the back of that, there are some clinical presentations that we have that a little bit of discomfort and pain is okay, and there are others where we go, that's a red light. Is it the same? Where do you sit with the TMJ in the way of sort of pain tolerance with those sorts of exercises?
For sure. I think, again, it depends on what is going on with the jaw. If I have somebody who's presents with a very irritable jaw, often they're probably more the acute jaw presentations. They might have a lot of irritation in those structures around the jaw and that retrodiscal tissue. I go way more gentle with those in terms of trying to improve range of motion, and probably lean into, in the early stages, things like manual therapy to try and facilitate jaw range of motion, and allow them to, I guess, have a little bit more range that they can exercise into comfortably. Compared to those that maybe have more chronic jaw problems, that we're probably not as worried with irritability. I think those are probably ones that we can push a little bit harder. So typically I tend to probably be a little bit more gentle in terms of exercise. Fatigue I'm okay with, and that guidance would probably be the similar level that I would target in other areas of the body as well. But pain, I think jaws can be a little bit reactive. So especially when I'm first getting to know someone, I probably want to be sticking a 4 or below if they're not irritable, and if they are irritable, I'm kind of using that, you know, it shouldn't increase by more than 1 or 2 initially, and then just monitor and see how they go. And if we're finding that we're getting good progress, we can always make that harder if need be.
Great guidelines. Thank you. Question 5, are there any specific pain patterns or symptoms that would rule in or out cervical spine versus TMJ? And what is the best way to differentiate?
Probably one of the most alarm bell ringing things that I start to think probably see spine over TMJ. Sorry, my dog's barking in the background. Is if I'm either they offer, or I find out at some point within the interview that they have a problem with their cervical spine as well, particularly if it's on the same side as what they're getting the pain, and or if they have a history of migraines and headaches and that kind of, you know, they've got a lot of cervical and orofacial pain preceding it. I'm probably thinking more so that I'm going to be more comprehensive in my cervical spine assessment than if they go, no, I've got no problems with my neck or my shoulder or my upper back at all, and it's very isolated to that jaw. So I think probably the spread of symptoms is something that always, you know, gets my brain ticking as to whether the cervical spine is contributing to that. The pain is probably the biggest one, but you can definitely see it with locking and clicking jaws as well. And again, probably the most helpful way that I try and differentiate is really just to use TDTs to change the position. If changing the position of the neck automatically straight away improves their TMD symptoms, then it's probably telling me pretty strongly that we need to be looking at the cervical spine, versus those that I might treat the neck or work on the neck or change the neck position and it doesn't really change their jaw symptoms at all. I'm probably not going to be spending as much time focusing on that.
And I suspect I know the answer to this, but do you typically go with one over the other first? Do you have a typical flow?
If I'm identifying that there's both neck and jaw problems, I tend to go neck first. The main reason being is the neck is the foundation for how the jaw moves. So if we do our, you know, reverse slump, head forward posture, and pay attention to where our teeth are touching on each other, and then sit up nice and tall, it changes our occlusal pattern immediately, which changes how the muscles work, how the joint's being loaded in the jaw. I think if somebody's presenting with both, or I'm thinking it could be either, I would typically choose one. Almost always that's the neck. Try treating that and see what change I get. And if it does change a lot, I'm going to keep persisting down that pathway until I feel like we either resolve it or we reach a plateau, and that's when I'd probably go more into the jaw.
Great answer. And it sounds like your brief corrections would almost be low-hanging fruit, not take long, and give you the direction.
For sure. TDTs, I love them in clinical practice because I think they are really helpful indicators. They're not always 100%, but they're probably one of the most helpful indicators that I've found that helps me try and figure out what's going to have the biggest effect. So if a TDT could be that I'm applying a glide to the jaw or the TMJ while they're opening or while they're doing their problem movement, or it could be correcting the cervical spine or moving the thoracic or the scap. Any of those, but it really helps me figure out where I should be prioritizing.
Fantastic, thank you. Which leads into the next question, cruising back up to the TMJ. Do you ever work with or refer to dentists for further assessment? And when would a dentist review be indicated?
Absolutely. I think the relationship between dentists and physios in this space is really, really important. And I think for anybody that is maybe starting to get into it or trying to get into it, dentists can serve as both a really valuable referral source, because a lot of people in the community might not know that either physios see jaw problems or TMD, or they might actually not know that the problem is originating from their jaw. They might present with either ear pain or, you know, face pain or tooth pain that is actually caused from TMD. So I think, first of all, that direction is obviously very valuable, but the direction backwards as well is also extremely valuable as well clinically. The main time I would refer to a dentist when I've got a patient maybe presenting to me that hasn't seen their dentist for their jaw problem would be if I'm suspecting there's a lot of bruxing, so clenching, grinding behaviors that are going on, that I might just want to make sure that the teeth are okay. Dentists are obviously fantastic at the very least kind of monitoring, so they might have an assessment, check where the teeth are at, and then just touch base every 6 to 12 months and make sure that they're not, you know, wearing down or loading the teeth in a way that's going to be unsafe for that person. So that is definitely very helpful, and they can be prescribing things like splints that might be important to protect that person's teeth so they're not fracturing teeth or cracking teeth because of those behaviors. Another time is potentially if I'm not sure whether it is TMD, or maybe someone's presenting with pain and it has got like a bit of a funny pattern along that mandible, but I think it's TMD, or maybe I think it's not TMD, but there's a lot of dental referred pain. I'd typically refer back to the dentist and just check that we're not missing anything from the tooth side of things. Tooth pain or pain originating within the tooth can refer along that mandible as well. So I think it's important that we're clearing that if they're getting tooth pain. And the dentists can usually do that quite quickly and confidently as well, that they can go, you know, it's definitely not coming from here, or it definitely is coming from here, we need to address this. So that is another really helpful, I guess, link that I would use quite commonly. Yeah.
Thank you. And
There's plenty of others, obviously, but I think those are probably the two kind of common bi-directional referrals that we'd see a lot of. Yeah.
And I feel like patients often offer that bit of information that they do grind or there is bruxism. People are quite aware of it, aren't they?
Yeah. And dentists, like, for the most part, dentists are so fantastic to work with this group, because we do have such distinct skill sets. So what we can offer as physiotherapists is quite different to what dentists can offer as well. And so having the combination of the two where needed is actually really important and really helpful.
Absolutely. Now, you mentioned facial pain, which is a good segue into the last question. And I encourage, if there is anyone that is watching that does have a question, feel free to pop it in the chat as well. But the question is, when would you suspect there are cranial nerve issues causing pain, i.e. the facial nerve, and how would you assess that?
Yeah, so a really common differential diagnosis from TMD is trigeminal neuralgia. Is probably one of the most common, just because of because of the nerve distribution. The type of pain and the behavior of symptoms are really big parts of the patient interview that's going to help me lean into that. Often the symptoms are less mechanical, and often they're kind of more of those, you know, sharp, shooting, zapping, zinging kind of sensations that might be associated with their jaw problem presentation. Compared to when it's muscular or disc or joint, often it is probably a little bit more predictable in terms of the behavior of symptoms. Yeah, compared to neural. It would be similar to, I guess, a radiculopathy versus a localized, you know, joint or muscle problem. We're really kind of thinking, is it more that nociceptive? Is it more that neuropathic presentation? And the other one that gets looped in quite a lot as well, just because TMD can link in with headaches, is migraine. And that is really, again, we're thinking of behavior of symptoms, the nature of the symptoms. Is it kind of spreading up? Are they getting that phonophobia, photophobia? Is it kind of episodic with triggers that aren't really mechanical? We might be thinking that it's not TMD and that it's one of those other differential diagnoses. Obviously, also the presence of neural related symptoms like certainly any facial droop is not normal for TMD. So immediately, if I'm seeing any of that kind of asymmetry on one side, that's definitely not normal for TMD. And I'd be thinking, is it neurological? Is there something else that I really need to be referring on to screen properly? And, pins and needles, numbness, whether it be on the face or in the mouth, the lips, the tongue, those are other things that are making me think it probably is less likely to be a TMD and much more likely to be a neural issue.
So it's sounding like before you even arrived at an objective assessment, the bulk of your screening between your sort of something that might be more neurological in nature is derived from your subjective examination.
For sure. And I think the other thing, trigeminal neuralgia, again, is probably the most common one that gets maybe overlapping or confused with TMD. Certainly within the interview, we'll see those very neural-like symptoms, where there's those zinging, zapping, sensitivity to cold or wind is another one. So they might say they kind of need to put a scarf on and rug up their face if they're going out in the wind. That again is probably starting to raise things to me that I'm thinking it could be that neural sensitivity or neural issue rather than, musculoskeletal per se. And within a physical examination, so definitely already by the time I'm getting to a physical examination, I'm probably starting to think, is it likely to be TMD or is it likely to be something else, a differential diagnosis? For neural symptoms, your hyperalgesia and allodynia often are way more sensitive just generally in that distribution of the nerve compared to, maybe over specific muscles or joints. Yeah.
Thank you. Great answer. We have a question from Matt. Matt, thank you for your question. It's a question relating to trigger points. The wall charts show referral into the teeth, for instance, temporalis. Is this your experience as well, especially with deep, dry needling eliciting twitch responses? Thanks, Matt.
Thanks, Matt. Yeah, so definitely I've, I guess, seen a number of people that maybe going back to the dentist referral question, they presented to their dentist reporting tooth pain. And the dentist has done all the testing on, there's nothing wrong with your tooth and it's actually coming from those jaw structures. So definitely referred patterns from muscles around the jaw, whether they're, masseter, temporalis is a big one, but even pterygoids can sometimes refer into those teeth on that side as well. So definitely, and what we'd be looking for in the physical examination with that is that where we're palpating is reproducing those symptoms as well. Yeah. Fantastic.
Thank you. Well, that draws us to a close of all of the questions we had submitted prior and in the chat. So thank you to everyone who joined live this evening. It's fantastic to have you all. And Alana, thank you so much for sharing more of your wisdom. That was fabulous.
No, thank you for having me. And thanks for everyone who, I guess, came on the night, as well as those that listened in retrospect as well. Hopefully everyone finds it helpful.
So we've also got away without saying, let's sink our teeth into it.
Yeah. No joy.
Not too late to throw a pun in. Fantastic. Thanks so much, Alana. Thanks, everyone.